I am delighted to have been invited to get to speak about this topic, which I think is important and often overlooked. So thank you so much for the invitation to talk about this. I'll be discussing how neuroendocrine hormone deficiencies might play a role in symptoms of people who have EDS. Neuroendocrine hormones include stress hormone, thyroid hormone, sex hormones, and growth hormone, and I'll be talking about those too. My interest in this began with the patient. And many like her. So this is a woman in her late 20s who had hypermobility EDS, POTS, and MCAS. She was initially sent to me for a taper of glucocorticoids. She'd been started on high-dose glucocorticoids for some of her symptoms, including fatigue, brain fog, and autonomic dysfunction. And as we spoke, she also mentioned, she'd had a host of concussions dating back to 10 years earlier, and every time she'd had a concussion, the fatigue and the brain fog had worsened. Didn't get better, kind of stepwise worsened each time. We successfully and slowly tapered the glucocorticoids off, found out that she didn't need them for replacement. They'd been used therapeutically, no adrenal insufficiency, and her fatigue and cognitive symptoms persisted and were notably impacting her quality of life. Because those are also symptoms of pituitary or neuroendocrine hormone deficiencies, and because we know that there's a higher rate of neuroendocrine deficiencies after concussions, we started an evaluation. These are some of her initial labs. Her cortisol, stress hormone, was high enough on that assay to say she didn't have adrenal insufficiency, which we knew. Her thyroid hormones, which I'll discuss more later, were normal. We didn't need to test her estrogen axis for the purpose of deficiency because she had regular periods. And her IGF-1, which is a hormone made in the liver in response to growth hormone, was normal. So given this panel, is there any reason to think she might have pituitary hormone deficiencies or that they have anything to do with her symptoms? And we'll discuss that today. The reason I'm using this image amongst the scream is that he said that the inspiration for his painting was that he sensed a scream passing through nature. And to me, this echoes what way too many people tell me, that they've experienced this really dramatic shift in who they feel like they are in their baseline, and also highlights the importance of setting expectations appropriately. So for patients who come in after concussions, I tell them all, one, we know that there's a higher rate of pituitary hormone deficiencies after concussions or more severe traumatic brain injury. That doesn't mean that all of their symptoms are due to hormone deficiencies, but that said, it's straightforward to test for them, to replace deficiencies, and any symptoms directly due to a hormone deficiency should be reversible over time with replacement. So that's why it's important to think about this, a potentially reversible component to symptoms. Okay, so then I set out to look, because her primary issue was EDS. What do we know about EDS and neuroendocrine deficiencies? For the first time in my career, I found this: nothing. We know nothing. There is no data at all. I tried a number of different searches, and then I thought, okay, is there a problem? Let's look for TBI. Maybe there's a higher rate of concussions. We know nothing. So ample opportunity for research. Now, there is some literature suggesting an association between persistent symptoms after concussion and EDS. Dr. Maitland mentioned Dr. Amonet, and he and his colleagues, in fact, suggest that trauma might trigger some of the symptoms or even trigger, therefore, the diagnosis of EDS based on some of his research. There's also a paper that was published in 2019 by Gami and Singman that described diagnosis of patients based on their presentation with persistent neuroophthalmologic symptoms after concussion. So is there, in fact, a higher rate of concussions in patients with EDS? Is there a reason to think about screening for that if patients aren't getting better after TBI the way they're expected to? These are the same patients who are often referred to me. I'm going to come back to the questions to consider later and talk a little bit now about why do we care about pituitary deficiencies? What do they do? Why do we care about them? And what do we know about them after concussion? We know that they're seen at a higher rate after TBI. Chronic anterior pituitary deficiencies are described in 15 to 60% of adults. I'm going to stop here a little bit on the terminology. Chronic meaning looking at least 3 months out. Anterior meaning the portion of the pituitary that controls stress hormone, thyroid hormone, sex hormones, and growth hormone. The posterior pituitary has to do with salt balance and is important in the acute period after concussion. And pituitary here is shorthand for pituitary or hypothalamus. I am not trying to ignore the hypothalamus. I'm just referring to the system. This 15 to 60% is too broad of a range to have it always be accurate. So if you go into the literature and look for who are the subjects that they're looking at, are we using the appropriate testing for pituitary deficiencies and applying the appropriate thresholds, you end up with about 25% of people with persistent symptoms after a concussion or TBI have a pituitary deficiency. This can be a mild concussion to a more severe TBI. It's also important to note that the symptoms don't always show up right away and the deficiencies don't always show up right away. There's a really interesting series of studies, some in children and adolescents and some in adults, looking at people 3, 6, or 9, and 12 months after the incident, after the injury. And certainly you see deficiencies at 3 months that have recovered by 12 months. But you also see deficiencies present at 12 months that were not there at 3 or 6 months. So it's important to think about this over time. Once you're at least a year out, growth hormone is the most common deficiency found when it's looked for. A lot of people have concussions, so there's a lot of interest in figuring out how do you know whom to screen. It's not feasible or cost-effective to screen every single person who ever had a concussion. Injury severity, while it used to be thought of, it has to be a severe injury to look for a deficiency in hormones. We know that's not the case. It can happen after mild concussions or repetitive sports injury as well. In fact, there's some data now that military blast injury without a physical impact also has the same effect. So the cause of injury does not appear to make a difference based on available research. On a patient-by-patient basis, there's not a role here for imaging in that you can have normal MRI or CT images of the brain and still have pituitary hormone deficiencies. There aren't clinically useful biomarkers, so the best we have is symptoms. So what are the symptoms? Patients who have pituitary hormone deficiencies have an impact on their overall health, on their quality of life. It's a particularly sensitive metric for growth hormone deficiency. And if not identified and replaced, there are not only increased morbidities, but also mortality. This is reversed by replacement. So the symptoms overlap to a high degree with symptoms for other reasons, for other issues that can sequelae of concussion, and EDS. Brain fogs, really executive function decrements, so difficulty with working memory, difficulty with focus and concentration, difficulty with multitasking, quality of life as mentioned, that can be mood changes, both cognitive and physical fatigue, exercise ability and stamina, and then these hormones also impact body composition, are important for cardiovascular health and for bone strength. The image there is of a pituitary. The gland hangs from a narrow stalk. That stalk contains the vessels and the nerves, and it sits in a bony saddle. So one of the thoughts of why there's a higher rate of deficiencies after concussion is that it might knock against the sella, the saddle, or it might twist on the stalk. There's another school of thought that maybe there's a neuroinflammatory cascade that gets set up. We don't know why in any one person there's a pituitary deficiency, but we do know that there's a higher rate. And the hormones that are managed by the pituitary that are made are growth hormone, LH and FSH, which lead to the production of sex hormones and manage fertility. TSH leads to the production of thyroid hormone, and ACTH leads to the production of cortisol. Now, the order in which I wrote these is the order in which we think they appear. So most common, at least a year out, is growth hormone. And even more important clinically is that they have to be replaced in the reverse order. So let's say somebody has, a peripheral thyroid hypothyroidism, not that uncommon, and their thyroid dose is increased. If there's adrenal insufficiency that has not been diagnosed or treated, it can precipitate an adrenal crisis. So it's important to think about. You need to start with replacing cortisol if there's an adrenal insufficiency, thyroid hormone, sex hormones if appropriate, and then the last is growth hormone. The way we evaluate them has entirely to do with these beautiful, elegant feedback loops. That's just how the neuroendocrine system works. I'm going to sort of gesture because I can't point, but the pituitary sits in the middle of this feedback loop system, and it acts a little bit like the thermostat in your house. So if the thermostat's set to a certain temperature, the house is too cold, you get an increased signal for heat. That's how the system works. If the thyroid gland at the base of the neck, I'm using this just as an example, isn't making enough thyroid hormone, and the central system is functioning appropriately, the pituitary senses this, and it sends out more TSH. On your annual screens with your PCP, TSH is generally checked. If it's high, they look for hormone deficiency with a low thyroid hormone. That's not enough if there's the possibility of a central deficiency. If the pituitary is affected, it can't make quite enough TSH. The thyroid gland can't make quite enough thyroid hormone. The pituitary usually maintains enough ability to respond to just get that TSH into the normal range. So a normal TSH in the presence of a low thyroid hormone is inappropriate. It indicates possible central damage. So you need to measure all of the hormones in each system. I'm not going to go through the testing as part of the talk, although I'm happy to answer questions, other than to mention that we used to think that for growth hormone deficiency, a low IGF-1 was an appropriate screen, and it's now clear that you can have a normal IGF-1 and fail the better testing, which is provocative testing, where you try to squeeze growth hormone out of the pituitary and see if it can mount the appropriate response. So what does this matter for our patient? This is the initial lab she had. And the IGF-1 was normal, but at this point there was 10 to 15 years of data saying that's not enough. So we did provocative testing with glucagon, and she failed it. She failed that test. Her growth hormone didn't get above 1, let alone 3, which is for patients with a normal range BMI, the appropriate threshold. She has growth hormone deficiency. This is too often overlooked in adults. Growth hormone certainly is important to reach adult height, but that is not all that it does. It affects lots of areas in the body. Adults with acquired growth hormone deficiency have difficulties with executive function, the brain fog to which this patient referred. Growth hormone is important for cardiovascular health, for bone strength. Quality of life is this particularly sensitive metric, and there's some questionnaires I use, but you can also just ask the patient. I use both. And body composition and exercise capacity are also dramatically affected by growth hormone. There have been studies of growth hormone deficiency in patients, particularly after TBI. Basically, they show that if you don't have enough growth hormone, you do worse than if you do have enough growth hormone. In the few studies of replacing in this population, there are definite benefits for cognition, quality of life, body composition, and there's lots more data in patients who have growth hormone deficiency for other reasons, like a pituitary tumor. These are missed all the time. We have the information. Here's a case where we actually have data, but there's not a lot of awareness of it, which is why I like talking about it. I think there's a lack of awareness among people who see patients with concussion. The symptom can seem pretty vague, right? I just don't feel like myself. I'm tired. There may not be complete understanding on the part of the person that patient is seeing about how to test for pituitary deficiencies, and there's some access to test issues that can arise also. And I mentioned already that TSH is one of these common barriers, also missed periods. I see way too often people who are like, yeah, I stopped getting my period regularly after my accident, but everyone told me I was stressed. Okay, stress can do that, but it's not always stress, and it's not always menopause, and that's a pretty easy thing to tell. The same way that the thyroid axis works, that's how the estrogen axis works. In normal menopause, the ovaries don't make as much estrogen. The pituitary puts at a higher level of FSH. High FSH, low estrogen, that's what you would see in normal menopause. If the problem is the pituitary or hypothalamic injury, you would have a normal or low FSH with low estrogen. It's a really easy check. Again, growth hormone deficiency may be particularly overlooked in adults if the thought is usually that it's just for height, and it is not. And I see too many patients who have a normal IGF-1, lots of symptoms, and the additional testing wasn't done. This is just to say that it's worth thinking about in patients who have concussions. It's worth getting them to somebody who can evaluate them. You can always discuss them and start the evaluation yourself as well, and that awareness is really important here. But how is this relevant if somebody has EDS? If they have a history of concussions, I just discussed exactly how it should be, highlights of how it should be addressed, and I'm happy to take any questions as well. And it might be appropriate if there are persistent symptoms to consider neuroendocrine evaluation. It doesn't mean those symptoms are due to a pituitary hormone deficiency, but it's worth looking for them. Again, because any symptom directly due to a hormone deficiency should be reversible over time with replacement. If somebody has growth hormone deficiency and their primary symptom is brain fog, I say at the outset, let's say 60% of that is due to deficiency, 60% should sort of return. It's also worth mentioning that these hormones are important repair hormones too, so can help in other ways as well. Many hormone deficiencies can be replaced. I say many here, not all, because you can always replace cortisol in somebody, you can always replace thyroid hormone, you can always replace sex hormones if appropriate, and there aren't contraindications, but growth hormone deficiency is different. It's more tightly regulated. To legally prescribe growth hormone replacement, you need to not only have a clearly diagnosed deficiency, but to have one of the recognized causes for it. And that's a pretty short list. TBI is on that list, still overlooked. Pituitary tumors, childhood growth hormone deficiency, radiation, EDS, we don't have enough data, it's not on the list. COVID, I think, may be related, not on the list yet. So here's where we need research. And again, symptoms should be reversed if they are due to the deficiency. So let's come back to the questions, because there are a lot of questions here, and I think some of them can be fairly simply answered if we ask, if we look. Is there a higher rate of pituitary hormone deficiencies in patients with EDS? Is this related to a background of concussions, or is there a different causal link? Are there more concussions? Again, if the symptoms of patients aren't getting better after a concussion, is that itself an indication to think about whether they may also have as yet undiagnosed EDS? So I'm leaving you with questions, but I hope we can work together to start to answer them. I'm happy to take any questions if there's time for it now, or by email, or at any time. Thank you so much.